Now it works after we've gone in and out a little bit. Sometimes it makes me wish for the days of Kodachromes that we could do that. So, what is the definition of a classification? I had to go to the dictionary first and see what a classification could mean. This is defined in dictionaries as a system of categories to which morbid entities are assigned according to some established criteria. The International Classification of Diseases version 10 has a fantastic way of saying what goes on the transplant. It's T8611 or T8610. That's not so very useful, is it? So the purpose, in my view, of assigning something to categories is that the criteria should be useful, hopefully clinically useful or research useful. They should be sensitive, they should be specific, they should be relevant to the disease. I think Lynn has just showed us examples of where you might wonder about the relevance of the classification data you're giving to the disease process. Very importantly, as we just heard, they should be informative for consideration of treatment, and ideally be based on evidence of disease pathogenesis etiology. We heard some points about that we may diagnose lesions, but we may not be diagnosing pathophysiology. So the evolution of recognition of rejection of kidney allografts, and I am senior enough to have, as a fellow, thought this was very easy. I could just hold up a slide and look at it without the microscope and see if it was blue or not. And if it was blue, it was rejection. And for those of you who are more junior than me, which are a lot of you, that was back when there was just steroids and Imuran. It was super easy to diagnose rejection. So then we learned that there was an inflammatory infiltrate. We got more data. I did know in medical school that there were B and T cells, but we got a little bit more information about these T cells. And then came along, after the first Banff meetings, the concept of antibody-mediated rejections. We had an evolution of understanding. And this is a biopsy from last week in my lab, a patient who, for illness and other reasons, quit taking their medicine for a week. And this is easy. This is the silver stain, but it was blue to the naked eye. This is easy. We don't need such very, very high-level classification to say this is really messed up in this clinical context, no medicine for a week, BK is negative. This is rejection. So the early definitions of T-cell mediated rejection by CCTT was a very interesting, a little bit medieval approach to deciding what the gold standard was for something being T-cell mediated rejection. These were patients, and this is before antibody-mediated rejection was recognized, patients who had biopsies for cause, and when they were treated with anti-rejection medication, they improved, and this was said to be rejection. So I have to do a little segue and tell you an anecdote from the late, great breast pathologist at Vanderbilt, Dr. David Page, who also did other pathology. Some other investigators at Vanderbilt published a series of patients with poorly differentiated carcinomas diagnosed in the lab that he oversaw at Vanderbilt in one of the oncology journals. I won't name who these clinicians were. And they said because these patients responded to germ cell therapy, these were very poorly differentiated germ cells. And David Page, I couldn't find the original thing, I have a picture of it somewhere, wrote a letter to the editor and said, this is not true, this is not valid, these were undifferentiated. And the famous quote was, just because you kill something with a rhinoceros gun doesn't mean it was a rhinoceros. So I want to put that in your minds, that the CCTT criteria for including cases as rejection was useful and good, but it may not be the gold standard. And they required 5% infiltrate in non-atrophic tubules and tubulitis. The Banff early criteria, when we melded this together, CCTT and Banff in 1997, the basis for the cutoff criteria that was chosen was not defined. It was based on the expertise and the considerable experience of people with 25% infiltrate and lots of tubulitis. So the utility of the Banff approach has been fantastic, with working groups, evidence-based consensus, great progress in several areas, but in my opinion, the criteria and the gold standard for T-cell mediated rejection criteria lag behind. The working group for revisiting criteria for TCMR is in progress, and it's been in progress for a long time. And the problem is the gold standard. How do you know that something is just T-cell mediated rejection? Well, you can rule out acute pyelo, you can rule out IgG4 related disease, you can rule out BK nephropathy, But back in the days when this started under the leadership of Volker Nicolai and others, it was not common that our patients had DSA, so we couldn't absolutely rule it out. So this has been going on. We have contributed after painful work with Megan Catt, my previous fellow, was on faculty with us, has gone back to be with family up in Ohio. I think we were able, after painstakingly looking for people where we had all the tests and DSA had been done and we had follow-up, came up with a whopping 17 cases. So it's very difficult to come up with, and this is in progress, which is great. So we are then left, because we have this very high standard of 25% infiltrate and a lot of tubulitis to diagnose rejection by Banff. A lot of cases have something less than that, and maybe the biopsies are done for cause. And what do we call that? Well, we call that borderline. So this is a problem in that these diagnostic criteria create dichotomous division where pathophysiological continuity exists. You've heard several speakers already talk about that. So naturally we'll have cases on the border. And this holds true with every laboratory test, with everything that we do, but the borderline is really big in Banff. In addition, the problem is when borderline is not just very large, when it's heterogeneous and a big proportion of cases. So this is my concept of borderline being very dangerous. Those of you who are younger may not recognize this is Checkpoint Charlie, dividing East and West Berlin. It's not a simple border where you pass into the country, right? Or from East to West Berlin. It is dangerous. It is really dangerous, and many people were killed trying to cross Checkpoint Charlie. So this is what I view borderline in Banff as. Here is another view of borderline. Here is a blue sky. Let's see, somebody. Yeah. It's a video. We tested it earlier. There, can you hit the arrow? Okay, this is a blue sky. Now it's partially cloudy. It's really cloudy, and now it's really cloudy. At what point do we make our plans and say, oh, it's a really nice and sunny day, it's a blue sky, it's partially cloudy, there are scattered clouds, or it's really cloudy? Maybe we'll deal with this around lunchtime as we try to make our way through the rain. But where is the cut point? Well, there is no specific cut point that goes from clear skies to just completely clear. So let me quote some of the early studies try to deal with this by great leaders, including Mark Haas here. Did a fantastic study over 20 years ago where he said the minimum threshold of tubular interstitial inflammation for the diagnosis of acute rejection is not clearly defined. So they looked at borderline biopsies, this big dangerous zone that I've defined for you, by Banff criteria who had no additional anti-rejection therapy. And they assessed for outcome and they compared the Banff versus CCTT levels for acute T-cell mediated rejection. So 17 of the transplant biopsies they looked at over 3 years who had this follow-up repeat biopsies not further treated were borderline by Banff. 65 of the 155 biopsies had no further treatment. So these were the patients that they looked at. So by CCTT criteria, that very low threshold, 47 patients, 72% had type 1 acute T-cell mediated rejection. In the follow-up biopsies, 15 of these developed acute T-cell mediated by Banff. So they went on from a low but detectable infiltrating tubulitis to a very high level. And those that had no rejection by CCTT in the follow-up, only 3 out of 18 progressed. Those that were then scored the same biopsies looked at by Banff criteria, these borderline cases, almost 3/4 of them did not progress to acute T-cell mediated rejection as defined by Banff. So that's pretty good, right? 3/4 did not progress. But looking at it the other way, 28% did progress to develop acute T-cell mediated rejection by Banff. So is that good enough that 1/4 of our patients that are borderline with no further treatment in a follow-up biopsy that was done for whatever cause showed rejection? Maybe not. So looking again at the clinical criteria, which really help to interpret what is going on, in this study they looked at patients with increasing or persistently increased serum creatinine, and the follow-up biopsies from these borderline showed acute T-cell mediated rejection in about half. These patients also had more frequent glomerulitis, so then we get into the conundrum. What exactly was that back in 1999? Probably they'd had some antibody-mediated rejection. I'll show you additional data in a few minutes that borderline category is heterogeneous, and it doesn't just have T cells going on in it. It has things stirring up antibody-mediated processes too. So how do they respond, these borderline biopsies, to therapy and other studies? Those that had borderline and other abnormalities, some scarring, some other things, only half of them responded. But those of them that only had borderline and that were treated, 80% of them got better. And we don't have lots of details about the criteria for that. In another study, 75% of the patients who had borderline, and again, the bias of the clinician, the sense in the center, responded and got better with treatment. So, what about these criteria for acute T-cell mediated rejection for cause versus protocol? So these were studies done by David Rush's group, again, a long time ago, protocol biopsies at different time points. These protocol biopsies had less rejection and less chronicity and lower serum creatinine at follow-up versus control without protocol biopsies, and they were treated with steroids. Well, does steroids just make everything better? I know almost every time I take my beloved dog to the vet, they may get antibiotics and steroids. It's rare that they don't get some steroids. And having had high doses of steroids for severe poison ivy, I can tell you it makes you really jazzed and energetic. So I don't know how we can say that, again, the rhinoceros gun means it was a rhinoceros, but people got better. And then again in the study from Shane Meehan from over 20 years ago, we believe that borderline lesions deserve further study in a similar prospective randomized protocol. So, borderline is heterogeneous. I've already alluded to that. From Mark Haas's early study, you can see the glomerulitis that developed. 146 patients studied by Brian Nankerville with consecutive borderline biopsies compared to control and those that just had T-cell mediated by Banff. Borderline, in those with decreased kidney function, many of them were treated. Almost half had suboptimal recovery, about a quarter had persistent inflammation, 50% went on to ATCMR. And very importantly, in some of these borderline biopsies, there was increased ABMR-related changes at 1 year after a borderline biopsy. Maybe they didn't all meet full criteria, but there was some hint of something perturbed related to ABMR. So, borderline being heterogeneous means that there has to be additional interpretation context. Borderline was interpreted in these studies that Brian reported on by the clinical team with integrated clinical-pathologic diagnosis as rejection with resulting treatment in about 70% of patients. Not all of them were treated, but 65.8% were treated. In those with protocol biopsies, not for cause, 28% had persistent borderline and follow-up biopsies. This is some sort of stable setting, protocol biopsy. You find some inflammation. Do we need to put them on steroids and then have all of the horrible side effects from that? What do we need to do? But a third of them had acute T-cell mediated rejection by Banff. And 2/3 of them resolved without treatment. So that is really, really troublesome that we have this huge borderline category. And within that category, some of them are going to get completely fine. Protocol biopsies, nothing done. Some of them are going to persistently have this inflammation, and some of them are going to develop acute T-cell mediated rejection. And these are completely different. Can you imagine if I were telling those of you who are nephrologists, I have inflammation, and I don't have an SV40 stain, and maybe it's polyoma because I see a few enlarged nuclei, maybe it's not. Those are completely different treatments, and these three categories have completely different treatments. So we have a dilemma. Our borderline is too big, too heterogeneous, and dangerously heterogeneous, and that's why I don't use that cutoff criteria. Let's look at more data from Dr. Nankerville. This was mild inflammation, borderline. Active inflammation with kidney dysfunction was found in some. And looking at the comparison, we heard already about the sheets of scoring for Banff and the errors. Jay told us that it's impossible not to make errors. So if you look at every number and it has to be exactly the same, then you get a very cruel, harsh kappa value of 0.11. If you look at broader, clinically important categories, the kappa is much better. So I will again quote Brian, because he's done wonderful work on this heterogeneous category of borderline. He says, we propose separation of borderline rejection into two subcategories according to the diagnostic probability of T-cell mediated rejection. Probable or suspicious, meaning it likely is a rejection, or possible with minimal or sparse inflammation, but meeting borderline criteria implies lower probability of T-cell mediated rejection. And this encapsulates why I do not use Banff. Just say borderline and then say below as a diagnosis, and then below borderline, but I think it's rejection, or borderline, but I don't think it's rejection. I use for T-cell mediated rejection, I said this meets CCTT criteria for acute T-cell mediated rejection, and for everything else we use Banff. So how have Banff criteria evolved for acute T-cell mediated rejection and borderline? I think we're kind of at the midpoint when we started with Banff for this. So what has been happening since that 1997 meeting, going from a Neanderthal pre-human era to somebody sitting at a microscope with all sorts of images? Well, I think we moved backwards because we had an unfortunate event happening where the criteria were modified, maybe intentionally or maybe through the complexity of all of the words in the report, to include isolated tubulitis without interstitial inflammation as borderline. So this is problematic, and there have been wonderful studies done and opinions written about this, and I'm sure that we will deal with this vigorously at the rest of the Banff meeting. So our evolution has so far been in the wrong direction. So I took some serious research to heart on this, and at the Comandatuba Bahia Banff meeting in Brazil that we already had an allusion to earlier in 2013 at the summary meeting, the last morning of the meeting, after we'd had wonderful scientific discourse. Some people, including Mark and Bob, played golf. I don't play golf, I went biking. I think everybody went swimming. I think we all experienced many caipirinhas. We all tried to dance after many caipirinhas. Some of this was successful and some of this was not. So after the culmination of all of this teamwork, I asked the leaders at the Banff meeting, and you know who you were, who amongst you used Banff threshold to say it's rejection? You only say it's rejection if it means Banff threshold. And not a single person said yes. I'm not going to identify you. So let's review how Banff thresholds for ATCMR meets criteria for classification I did in the beginning. The criteria should be useful. It's very useful for antibody-mediated rejection, for many other things. It's not so useful for sensitive and specific diagnosis of T-cell mediated rejection. So not so sensitive, not so specific. Does it have relevance to the disease? Yes, but what exactly is that disease? Is it stable inflammation? Is it something that's going to evolve to T-cell mediated rejection, to antibody-mediated rejection? We don't know. So yes, it's informative that maybe there should be consideration for treatment, but it's not granular enough. Is it based on evidence of disease pathogenesis etiology? Well, yes, some, but maybe not quite enough. So we should be separating borderline rejection into more fine-tuned categories, but we don't know whether the aerial infiltration, again quoting Brian, density of inflammation, immunophenotype of infiltrating cells, presence of intergraft, specific subsets of T cells, or the edema or extent of tubulitis can discriminate amongst these subcategories of borderline rejection. This is currently unknown. So are we just completely out in the wilderness? He says additional research is required to determine meaningful subcategories of borderline lesions. So the challenges that I put forth for the rest of this meeting for all of us is, what is the gold standard to set thresholds for acute T-cell mediated rejection? There are numerous causes that contribute to graft injury. It's difficult to define the impact and mechanism of one type of immune injury. We need evidence-based approaches with integration of morphology and other state-of-the-art markers to more accurately diagnose this type of rejection. So I would conclude that the threshold for acute T-cell mediated rejection by Banff was not so far based on evidence. Subsequent studies show a significant portion of borderline behave as acute T-cell, but it's a large and heterogeneous category. Some of them do not, and some of them get a flavor of antibody-mediated rejection. So this is how I think we're beginning to work already with integrated pathology. We have to have the clinical phenotype. I've had a biopsy that just said kidney, increased creatinine, and I diagnosed acute interstitial nephritis. I called for the clinician, not available, I left my pager. Immunofluorescence was negative. I looked for all of the things: granular tubular basement membrane deposits, anti-TBM, virus, everything. I had EM the next day, nothing. I called the clinician again, not available, and an outside clinician, not a Vanderbilt one. And then before I started doing my report, I did something absolutely brilliant. I called and asked for the nurse working with that clinician. So I said, this is Dr. Fogo. I have a biopsy on Dr. Smith's patient, Mr. Jones, and I just wanted to convey something about the clinical setting. She'd go, oh, that poor transplant biopsy, hon, what did you find? So I said, oh, he has a lot of interstitial inflammation and tubulitis. It looks like T-cell mediated rejection. I'll get a report to you later. Please tell Dr. Smith he can reach me if he wants. So I knew the clinical phenotype, right? Lynn alluded to this, that sometimes we don't even know if it's transplant or not. Maybe we can get better molecular omics. Maybe we can have AI assist us to the things that our eyes, due to bias or habit, are not noticing. And we can have an improved future for diagnosis and classification. So this is the future as I see renal pathology with the morphologic pathology. I don't think it's going to go away right away. Molecular pathology, that's where we are right now. And then integrated pathology with omics, AI, liquid biopsy, the history, feeding into each other so we can provide the best and most granular information for our whole team to be involved with the treatment of our patients and the outcome. So I thank you very much for your attention. I look forward to Brian giving additional perspective on this conundrum. Thank you. For those of you who don't know me very well, I'm from Norway, and this is a friendly picture of the very friendly border between Sweden and Norway. And that's my goal for Borderline down the road. Thank you very much.